Hi, I'm Dr. Chris Lewis. I'm one of the chief educators here at Doctors in Training. Welcome to another pharmacology lecture. I hope some of you are anxious today because today we're talking about anxiolytic and hypnotic drugs. At the very least, I hope I put some of you to sleep. So let's talk about anxiety. So it's an extremely common problem. It's estimated that about 4% of the population will have generalized anxiety disorder sometime in their lifetime. About 5 to 8% of primary care visits are directly for generalized anxiety disorder. Now there's multiple symptoms including tension, palpitation, nervousness, fear without a source, impending doom, and there's also a sympathetic activation. So patients will get sweating, trembling, tachycardia. The fight or flight mechanism starts to increase. So what goes on neurotransmitter-wise? So you get an increase in norepinephrine, you get a decrease in GABA, which we'll talk about in detail here in a little bit, and a decreased serotonin level. Now, severe symptoms can even mimic heart attacks or pulmonary embolisms. You'll see patients in the emergency room with chest pain, and it's a result of their anxiety. Now, we'll talk about treatment in regards to pharmacology here in a little bit, but we also need to say that cognitive behavioral therapy or psychotherapy is also very effective in the treatment of generalized anxiety disorder. It's not used as often, and in my opinion, not used often enough by both patients and physicians. So, another problem, insomnia. So insomnia is probably even more common than anxiety. A survey of primary care patients found that 69% of them had some degree of insomnia. Now most of these, about 50% of that was occasional insomnia, but upwards of about 19 to 20% complained of a chronic insomnia. It tends to worsen with age. Women will have this problem about 50% more often than men. Now there are some criteria we try to use for insomnia. So patients will have a complaint of difficulty initiating the sleep, they have problems maintaining the sleep, or they also complain of waking up too early and not being able to go back to sleep. So these above difficulties will occur despite adequate opportunities for sleep. And then finally, the impaired sleep needs to produce some deficit in daytime function. So drowsiness, lost productivity, other problems as well. So this can worsen mood disorders. So anxiety, depression, other mood disorders tend to get worse with insomnia. As I mentioned before, lost productivity is a big deal. People just don't work very well when they're sleep deprived. Now it has been a boon for the energy drink industry. The high sugar, high caffeinated drinks are doing very well now. So sleep hygiene is an important thing we need to discuss with our patients. Before we reach for drugs, we need to talk about how people can help themselves without medication. So first is maintain a regular sleep schedule. Go to bed at the same time every night, wake up at the same time every morning, even on the weekends. Don't force sleep. You don't want to lay in bed for long periods of time trying to sleep when you can. You want to avoid caffeinated beverages after lunch. Avoid alcohol near bedtime. Adjust the bedroom environment, so keep it dark. So if you're a daytime sleeper, you really need to black out your windows. Keep a good temperature, not too cold, not too hot. Regular exercise is helpful, though you want to do this 4 or more hours before bedtime. And don't overstimulate yourself just before bed. I'll have pediatric patients come in who complain of not being able to sleep, and they've just got done playing a very violent video game right before going to bed, and lo and behold, they can't sleep very well. So let's move on to the medication. So first are the benzodiazepines. Let's talk about the mechanism of action. So they target the gamma-aminobutyric acid, or GABA. We'll talk about GABA receptors extensively throughout this lecture. So GABA is the primary inhibitory neurotransmitter in the CNS. And when GABA binds to a GABA receptor, a chloride channel is triggered to open. And the influx of chloride into the neuron causes a small hyperpolarization which inhibits action potentials and thus decreases neuronal firing. So now there's 3 major types of the GABA receptor. The first one is an alpha-1 GABA-A receptor, and so when benzos bind to the receptor, it alleviates seizures and provides sedation and anterior grade amnesia. The alpha-2 GABA receptors, after a benzo will bind to these receptors, you'll get reduced anxiety and it'll relax spastic musculature. And then there's also a GABA-B, which is bound by a medication called baclofen in the spinal cord, and it relaxes spastic musculature as well, but we won't talk about that one quite as much as the other two. So benzodiazepines bind to the GABA receptor and enhance the action of GABA to open the chloride channel. So it increases the frequency in which the channels open. Let's talk about the duration of action of specific benzodiazepines. So first are the long-acting benzodiazepines, and they have a half-life of 25 to 100 hours, so they're quite long-acting. Examples of this include clonazepam or Klonopin, chlorazepate, chlordiazepoxide, diazepam, which is also known as Valium, flurazepam, and quiazepam. Second are the intermediate-acting benzodiazepines, and these have a half-life of about 10 to 15 hours, and that includes lorazepam, also known as Ativan, temazepam, also known as Restoril, and alprazolam, also known as Xanax. Now, Xanax or alprazolam is also considered a short-acting benzodiazepine by some people. Now, there's some ultra short-acting benzodiazepines. Their half-life less than 10 hours, and that's oxazepam and triazolam. Next, let's move on to the clinical uses of benzodiazepines. So, number one, we've been talking about anxiety disorder. So, effective for panic disorder, generalized anxiety disorder, social anxiety, performance anxiety, post-traumatic stress disorder, obsessive-compulsive disorder, phobias such as flying. The long-acting benzos, clonazepam, lorazepam, and diazepam are preferred for patients who need long-term daily treatments for their anxiety disorder. The short-acting benzos, like alprazolam, which is probably the most commonly used benzodiazepine out of all of these. Now, these are preferred for short-term anxiety problems or for abrupt, severe panic attacks. And one of the reasons why we prefer some of the short-acting medications is that they work quickly. Now, the problem is that they have more withdrawal symptoms and the addiction potential is much higher. It can also be used for a sedative or for a sleep aid. Now, not all benzos are good sleep aids. Now, all of them are sedatives, but not all of them can improve your sleep. It can decrease the time to sleep onset. They can increase time in stage 2 of non-REM sleep, but it can also decrease REM and slow wave sleep in general. You can have some residual morning sleepiness, and this is a common side effect. Now, there are 3 medications mentioned in Lippincott's that are used a little bit more often for insomnia. However, a lot of the other benzodiazepines can be used as well. So the first one is flurazepam, and this is a long-acting benzodiazepine. Its half-life is 1 to 3 days, but its side effect is that it does have a lot of daytime drowsiness. Temazepam, or the Restoril that we mentioned before, is an intermediate-acting. It does have peak sedation at about 1 to 3 hours. It's pretty useful for people who can't stay asleep. They have okay time getting to sleep, but they can't stay asleep. Now, triazolam is very short-acting, good for patients who can't fall asleep, though tolerance does develop quickly and should really only be used for 2 to 4 weeks. Benzos also are used as an anticonvulsant. So diazepam and lorazepam are drugs of choice for this. They're used to terminate grand mal epileptic seizures and status epilepticus. There are multiple forms that can be used, including an IV form, an oral form, and there's also rectal gel. There's even a nasal inhalant form of lorazepam that can be used. Benzos are sometimes used for muscle relaxants. Diazepam is often used for this. It's effective in treating skeletal muscle spasms due to strain or in spasticity from MS or cerebral palsy. Another use is for alcohol withdrawal and treatment. So there is a cross-tolerance between benzodiazepines and alcohol, and this can be helpful for detoxing patients. So medicines that are often used, diazepam, oxazepam, chlordiazepoxide, and chlorazepate are often used. It helps in preventing the withdrawal-related seizures. And we should probably mention, more specifically, delirium tremens, or DTs. And these are good test questions for medical students. So usually DTs start about 48 to 96 hours after their last drink, and it'll include hallucinations, disorientation, tachycardia, hypertension, fever, agitation, and diaphoresis. And this is important because mortality can be upwards of about 5% for patients experiencing DTs. The benzodiazepines can also be used for amnesia, so it can be used as a pre-medication for procedures such as endoscopy or bronchoscopy. Conscious sedation allows the patient to react to instructions during procedures but not really remember what happened afterwards. Midazolam is an injectable benzo that can be used for the induction of anesthesia as well. Let's talk a little bit about the pharmacokinetics. So benzodiazepines are lipophilic and they're rapidly absorbed after oral intake. They distribute throughout the entire body. They cross the blood-brain barrier, obviously. They're metabolized in the liver and excreted in the urine. It does cross the placental barrier and may depress the CNS of the newborn if given before birth, and it's also found in breast milk. We need to talk about dependence. This is a big problem with benzodiazepines, especially the short-acting benzodiazepines. They are known for being street drugs and used as recreation drugs. Withdrawal symptoms include basically the opposite of what the benzos do, so they can cause anxiety, agitation, confusion, restlessness, insomnia, and seizures. Adverse effects, drowsiness. This is by far the most common problem. Though if you take enough of this, you can get confused. It occurs more on the higher doses, as I just mentioned, and also with combinations of other CNS depressants, and also in the elderly. You've got to be very careful giving benzodiazepines to our older patients because they can have problems with that. The fast-acting benzodiazepines can elicit a rebound anxiety and insomnia very quickly. So if they're used to taking their fast-acting benzos on a regular basis, if you take those medications away, they will not do very well. And respiratory depression, though you have to take quite a bit of the medication to elicit this response. Contraindications. You got to be careful with patients with liver disease. You want to avoid an acute narrow angle glaucoma. Alcohol and other CNS depressants will enhance the sedative effects of benzodiazepines. You want to avoid in asthma attacks to help prevent further respiratory depression. And then overdoses are rarely fatal unless the benzodiazepine is combined with other central nervous system depressants. Let's talk about a benzodiazepine antagonist. So this medication is called flumazenil, and it's a GABA receptor antagonist, and it can rapidly reverse the effects of benzodiazepines. There's only an IV form for this, and it's used for benzodiazepine overdoses. Now the problem is that it can precipitate withdrawal symptoms. So you can give this to someone who's chronically using benzodiazepines and elicit withdrawal problems. It can cause nausea, vomiting, dizziness, agitation. But it can be often used when patients are coming in altered and you're not sure what they're on. You can give them flumazenil to see if at least you can bring them out of whatever stupor they're in. Now our next section is on other anxiolytic drugs. And the first one is called buspirone. And this is used in generalized anxiety disorder. It's not used for panic disorder because it does take a little bit of time to start working. It's about as efficacious as benzodiazepines, but it does work on different receptors. So it works on serotonin 5-H21A receptors and dopamine A2 receptors. There is less sedation, which is nice because it's not working on those GABA receptors. It can cause, strangely enough, hypothermia, and it can increase prolactin and growth hormone. And you will also get headaches on this medication as well. Dependence is low, though as I mentioned before, there is a slow onset of action, so it's more for generalized anxiety. And it is a cytochrome P450 metabolizer. Hydroxyzine is another medication. Now it's a first-generation antihistamine. It has very low abuse potential, though its side effects are drowsiness. Finally, let's talk about the antidepressants, the selective serotonin reuptake inhibitors and the serotonin norepinephrine reuptake inhibitors. Now, in general, these are the first-line agents for generalized anxiety. We've been talking about the benzos and how great they are, but in general, we like to use these medications more often because there's lower abuse potential, there's fewer side effects, and this will be discussed in detail in another lecture.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
How are you feeling, 00? Sweating, nausea, confusion, palpitation?
What have you done to me?
I haven't done a thing. It's your own ways that'll be your undoing.
I simply kept you locked up here long enough to let your body fully metabolize your precious vodka.
No martinis means
No double O.
You are sick, Gold. You have reached a new low. What's happening to me? I'm having withdrawal seizures.
Don't make me laugh. Alcohol withdrawal causes generalized tonic-clonic seizures. You're just a little tremulous.
If I could just reach my pen.
No, there's no escaping this time, Double O. No!
Don't you know the treatment of choice for alcohol withdrawal is benzodiazepines? I never go on a mission without a dose of chlordiazepoxide.
No!
That's right, Gold. Run scared. No one comes between me and my martini.
All right, so let's go through quick review number 1 in your study guide. The first question, name the 3 criteria needed for the diagnosis of insomnia. So you have to have a complaint of difficulty initiating sleep, difficulty falling asleep, difficulty maintaining sleep, and or waking up too early. So I often ask patients when they say, I just can't sleep, are you having trouble falling asleep, are you having trouble staying asleep, or both? You have to have this difficulty despite adequate opportunities for sleep. Obviously, if you've got a 2-month-old infant at home who's getting up every 3 hours to feed, and you're waking up to feed the baby, that's not, you don't have insomnia, you've got a 2-month-old at home. And then the third important point, the impaired sleep produces deficits in daytime function. So you're not able to function because you're too tired, you're just too sleepy. Next question, what is the primary inhibitory neurotransmitter in the CNS? Well, this is GABA, and that's important to know, especially because of the benzodiazepines, and then we're going to talk about the barbiturates shortly. So GABA is the important primary inhibitory neurotransmitter in the CNS. Next question, what's the major drawback of using short-acting benzodiazepines for long-term anxiety control? Well, these are short-acting, and their effects in the body wear off quickly. So when they wear off, the patient who had some anxiety is now feeling anxious again. And they like that nice calm feeling, so they're going to take another benzodiazepine. And then it's going to work for several hours, and then it's going to wear off. They're going to feel anxious, and they're going to take it again. So they keep taking it and keep taking it and keep taking it. And because of this, they have an increased addiction potential. The patient's used to taking them all the time, and they're becoming more addicted to them, which makes them less than ideal for the management of chronic anxiety. The next question, match the GABA receptor with its action. So the first one there, the alpha-1 GABA-A receptors. These are the receptors that alleviate seizures. The alpha-2 GABA-A receptors reduce anxiety. So both types of GABA-A receptors are ion channels. What ion do they allow to pass through the membrane? Chloride ions. Benzodiazepines increase the frequency of opening of these chloride channels, which tends to stabilize the negative membrane potential, inhibiting further depolarization and preventing the downstream neuron from firing. Then the other receptor there is the GABA-B receptor, and these aren't ion channels, these are G protein-linked receptors. They're bound by the drug baclofen, which is a derivative of GABA. GABA-B receptors, although they're G protein-linked receptors, they have a downstream effect of opening potassium channels, and that further hyperpolarizes the cell. So whether it's acting on the GABA-A receptor or the GABA-B receptor, the net effect is hyperpolarization of the cell or stabilization of the cell membrane. So it's going to inhibit further neuron firing downstream. Next question, what are the symptoms of delirium tremens or DTs? Well, delirium tremens occurs due to alcohol withdrawal, and it usually occurs 2 to 4 days or 48 to 96 hours after the patient last had a drink. So you might see this in a patient that's hospitalized for something completely unrelated, and maybe they weren't entirely honest with you when you asked them, how much alcohol do you drink? And so after 2 or 3 days, they're not getting any alcohol, and they start to go into DTs. So the symptoms of DTs may include hallucinations, disorientation, this is the delirium we're talking about, tachycardia, hypertension, fever, agitation, and diaphoresis. Now, at some hospitals, you can actually write an order for a beer to be brought with each patient meal. So they just have a little beer, they get a little alcohol, it prevents the DTs altogether. Or, if that's not an option, you may need to start a long-acting benzodiazepine to prevent DTs while they're in the hospital and they're not able to drink any alcohol. Next question. A 42-year-old female presents with rare, abrupt panic attacks that are usually associated with air travel. Which benzodiazepines would be the most appropriate? Now, this is a fairly common clinical situation, something patients will ask you about. Can I get something to help when I have to go on this flight that I have coming up? The best treatment for this would be a short or intermediate-acting benzodiazepine, something like alprazolam. Now, I usually ask these patients, when are they going to be flying, and how long is the flight, and how many pills do they think they need? And if they say, oh, I need just a couple pills, I need one each way, I'll write a prescription for 2 or maybe 4 or 6. That way they don't have to keep coming back every time they have a flight. But if they say something like, well, I'm going on this one flight and it's about 3 hours long, but just give me a prescription for 30 pills, I think maybe something's up. So you want to use your judgment. The patient may know that a good story will get them the drugs that they really are seeking. Next question. A 53-year-old male with generalized anxiety disorder is taking alprazolam 3 times a day. His alprazolam is not as effective now compared to when he first started taking the medication. In between doses, his anxiety is spiking. How would you change this patient's treatment? Well, one option would be to start an SSRI or an SNRI. These are typically called antidepressants, but they do work very well in the treatment of anxiety long term. You could also attempt to switch the patient from alprazolam to a longer-acting benzodiazepine. But again, there's still the potential for addiction and abuse. So I think, generally speaking, long-term treatment of anxiety should use something like an SSRI or an SNRI. Next question, what is the clinical use of buspirone? Buspirone is recommended for, or it's indicated rather, for generalized anxiety disorder, but not panic disorder. So what's the difference? Well, generalized anxiety disorder is characterized by generalized anxiety, typically developing over time. It's not related to a specific event. Just life in general is just overwhelming to the patient, and it provokes these low levels of anxiety. And this interferes with functioning. So it's disturbing to the patient, but it's not these massive, florid panic attacks. Panic disorder, you have these severe panic attacks with a rapid onset. It can occur following a specific event, but not always, and the specific event may not be identified. This is different than post-traumatic stress disorder. So again, buspirone is indicated for the treatment of generalized anxiety disorder, but not panic disorder. The last question, on which receptors does hydroxyzine act? Well, hydroxyzine is an antihistamine. It is acting on the H1 histamine receptors. It's sedating, so that's why it can be used for the treatment of anxiety. It's going to sedate the patient, calm them down a little bit. So that's it for quick review number 1. Let's get back to Dr. Lewis.
Moving on, let's talk about the barbiturates. Now, in general, these have largely been replaced by the benzodiazepines for sedation and for sleep. There's a high tolerance problem, there's an addiction potential, there's severe withdrawal symptoms, and one thing you probably need to know more than anything is that you can cause coma and death with overdoses of these medications. It's one of the oldest anti-seizure drugs classifications that we use. So let's talk about the mechanism of action. So they act on GABA-A receptors, and we talked about those receptors earlier in the lecture, and they prolong the duration of the chloride channel opening. So how do the benzodiazepines work? Well, they increase the frequency of the openings of the chloride channels. Well, the barbiturates will prolong the duration of those chloride channel openings. So they can block glutamate receptors. So anesthesia concentrations of phenobarbital can block high-frequency sodium channels, and these actions can lead to CNS and respiratory depression. At high dosages, this leads to coma and death, as we mentioned before as well. Let's talk about the classifications of the barbiturates. So long-acting barbiturates, 1 to 2 day half-life, phenobarbital. Short-acting, more 3 to 8 hours, pentobarbital, secobarbital, and amobarbital. And then there's an ultra-short-acting thiopental, and that's about a 20-minute half-life. So let's talk about the clinical uses. So for anesthesia, the thiopental that we just mentioned can be used for anesthesia induction. Originally, these were used as an anticonvulsant medication. So phenobarbital is often used for tonic-clonic seizures, status epilepticus, and eclampsia, and also with children with febrile seizures. Anxiety, it can be used as a sedative, though this has mostly been replaced by the benzodiazepines. And phenobarbital can increase liver enzyme synthesis in order to treat Crigler-Najjar type 2. Pharmacokinetics. So these are absorbed orally and distributed throughout the whole body. They cross the placenta and can depress the fetus. They're metabolized in the liver, and they're excreted in the urine as inactive metabolites. For their adverse effects, and there's a lot of them, CNS depression is the big one. It impairs concentration. You can get a lot of drowsiness. It synergizes with ethanol. Respiratory depression, this is where it starts to get dangerous. So it suppresses the hypoxic and chemoreceptor responses to CO2. And this overdose, again, can lead to death. Methohexatol and thiopental can cause laryngospasm during anesthesia induction, so you have to be careful about that. So in regards to drug interactions, it is a cytochrome P450 inducer, so this will decrease the duration of other drugs metabolized by the cytochrome P450. It's contraindicated in patients with porphyria. The barbiturates will increase porphyrin synthesis. Physical dependence, so withdrawal symptoms will include tremors, anxiety, weakness, nausea, vomiting, seizures, delirium, and cardiac arrest. So let's talk about overdose. Now this classification of medications are notorious for drug overdose. And usually the treatment is mechanical ventilation, purging of the stomach, and hemodialysis. You can also alkalize the urine to help aid in the elimination of phenobarbital. And unfortunately, there's no barbiturate antagonist like we do for the benzodiazepines. Next, let's switch gears over to sleep aids. So hopefully you can stay awake for this. First one we're going to talk about is zolpidem, or also known as Ambien. Now it works on BZ1 receptors. It's very good for sleep initiation. Unlike the benzodiazepine, there's no muscle relaxation or anticonvulsant effects. There's fewer withdrawal symptoms. There's almost no tolerance with prolonged use. And the rapid onset is at about 1 hour. The elimination half-life is about 2 to 3 hours. There's an extended release version. It's also called Ambien CR, which can also be helpful to help keep people asleep as well. Adverse effects, so people can have nightmares, agitation. You'll have some patients who sleepwalk or have conversations with people that they don't remember. Headaches are common, and daytime drowsiness can also occur. The next medication is Zaloplan, also known as Sonata. And it's similar to zolpidem, and it has fewer residual effects than the zolpidem. Its half-life is only about 1 hour. Good for initiating sleep, not particularly good about keeping people asleep because it wears off so quickly. The next medication is ezopiclone, also known as Lunesta. And it's similar to zolpidem and Zaloplan. It has a rapid onset of action, about 1 hour, and its elimination half-life is 6 hours, so it lasts a little bit longer in the body. Adverse effects include anxiety, dry mouth, headache, and drowsiness. The next medication is Ramelteon, also known as Rosarum. It works on melatonin receptors. So the MT1 and the MT2, it'll activate these receptors. So how does it work in general? Well, sunlight on the retina will transmit a signal that inhibits melatonin release from the pineal gland. And then darkness, conversely, will allow melatonin release. So this is how our circadian rhythm is produced. So it's indicated in patients who have difficulty falling asleep, and not so much in keeping people asleep. It has a low abuse potential and no withdrawal. It can be used for long-term use. Its adverse effects will include dizziness, fatigue, and somnolence, and it can increase prolactin levels. Next is chlorohydrate. It's a derivative of acetaldehyde and is converted to trichloroethanol. And it will induce sleep in about 30 minutes. Its duration is about 6 hours. Now, it does have some GI side effects, and it does have a very unpleasant taste, and it's not used that often. It can also synergize with ethanol. This medication was used in the pediatric population quite a bit, and it's still used some today. Antihistamines, these are widely available as an over-the-counter version of sleep aid. These are just the H1 receptor blockers. Diphenhydramine is probably the most commonly used one. It's useful for mild insomnia. The adverse effects will include anticholinergic effects, and it can cause some daytime drowsiness as well. Let's switch over to ethanol. Now, ethanol does have anxiolytic and sedative effects. It's metabolized by the liver to acetaldehyde and then to acetate. It binds to acetylcholine, GABA, serotonin, NMDA receptors. And it can synergize with benzos and antihistamines and barbiturates. And obviously, we all know this, chronic consumption can lead to liver disease, cardiomyopathy, nutritional deficiencies. Benzodiazepines are the treatment of choice for withdrawal, and carbamazepine is used to treat withdrawal-induced seizures. So let's talk a little bit about disulfiram, or antabuse. It inhibits aldehyde dehydrogenase and thus prevents the transformation of acetaldehyde to acetic acid, and this causes an accumulation of acetaldehyde in the blood. So the disulfiram-like reaction, so what does that include? That includes flushing, tachycardia, hyperventilation, and nausea. And it's been used for alcohol abuse for some time now because it gives you such a negative effect for drinking alcohol that people tend not to want to drink when they're on the medication. So what other medications give you the disulfiram effect? Well, certain cephalosporins, cefotetan, metronidazole, first-generation sulfonylureas, tolbutamide, and procarbazine. Another medication that we use is naltrexone, and it's an opioid antagonist, and it's an injectable, and it can be used for alcohol dependence as well, though the antabuse is probably used more often. And one final medication that's not used terribly often is a camprosate, and this has an unknown mechanism of action, but it's also used in alcohol dependence. It might show up on a test somewhere. So that concludes our lecture on anxiolytic and hypnotic drugs. I hope you're a little less anxious, maybe a little more sleepy right now, and I'll see you next time.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together we'll go through the quick review in the study guide.
Oof! All this talk of hypnotic drugs is making me sleepy. Benzodiazepines and barbiturates both act on chloride channels. But how? What's the difference? It's easy. Barbiturates increase the duration of chloride channel opening, while benzodiazepines increase the frequency of chloride channel opening. You see what I did? I changed barbiturates to barbiturates. And I changed benzos to frenzos. Pretty clever, huh? Yeah, well, I didn't win the Nobel Prize for nothing, you know.
So let's look at quick review number 2. What 3 receptors can barbiturates affect? Well, the primary effect is on GABA receptors. Barbiturates are going to increase the duration of chloride channel opening. Unlike benzodiazepines, which increase the frequency of chloride channel opening, barbiturates also antagonize glutamate receptors. Glutamate is an excitatory neurotransmitter, so if you're antagonizing that, you're going to reduce excitation, and again, you get the same effect, you get inhibition. And then finally, high doses of barbiturates affect high-frequency sodium channels, which lead to CNS and respiratory depression, which is a big problem. The next question, which barbiturate is most often used for anesthesia induction? Well, this is thiopental, and it's used because it's a very short-acting drug with a rapid onset. So you can give it a little bit, knock the patient out, and then it's going to wear off quickly. Next question, how do the barbiturates cause respiratory depression? Well, they suppress the hypoxic and chemoreceptor response to CO2. And obviously, if the patient's not sensing the high levels of CO2, they're not going to continue breathing because CO2 drives the respiratory rate. Next question, list the cytochrome P450 inducers. The mnemonic for this is BCG PQRS. Now, this is not a complete list of every drug that's going to induce cytochrome P450 by any stretch of the imagination, but it's a good start. It's an easy list to remember. So the B is barbiturates, C is for carbamazepine, G is for griseofulvin, P is for phenytoin, Q is for quinidine, R is for rifampin, and S is for St. John's wort. So barbiturates and the rest of these drugs on the list will induce the P450 enzymes, and they may cause drugs that are metabolized by P450 to be metabolized more rapidly because you have more of those P450 enzymes active. Now, this can either increase the potency of the drug if the metabolites are active, or commonly this will decrease the potency of the drug if the P450 rapidly metabolizes the drug to an inactive form. Next question, what are the major advantages of zolpidem over benzodiazepines in regards to insomnia treatment? Well, zolpidem will cause fewer withdrawal symptoms, and there's almost no tolerance with prolonged use. So it's a pretty good drug. Next question, if a patient wanted to try an over-the-counter sleep aid, what could you suggest? Well, one over-the-counter drug that's commonly used to help with sleep is diphenhydramine, or the brand name is Benadryl, and there are lots of other brands out there that include diphenhydramine. One of the most commonly used ones is Tylenol PM. Patients will say, oh, I just take Tylenol PM and it helps me sleep. Well, Tylenol PM is just acetaminophen, or Tylenol, combined with diphenhydramine. Unfortunately, diphenhydramine is not really an ideal drug for long-term use, especially in elderly patients. In addition to its antihistaminic effects, which causes sedation, it also is a good anticholinergic drug, which will cause a lot of unwanted anticholinergic side effects, including being hot as a hair, dry as a bone, red as a beet, mad as a hatter, bloated as a toad. So you get a lot of anticholinergic effects. You don't really want to use diphenhydramine long term. Sometimes patients will use natural supplements such as melatonin or valerian root. Neither of these is terribly effective. The next question, why shouldn't a patient combine alcohol with benzodiazepines, barbiturates, or antihistamines? Well, all these medications will synergize with alcohol and cause more sedation and potentially respiratory depression. It's especially a problem with the barbiturates. So you don't want patients to use benzodiazepines or barbiturates with alcohol. The next question, match the medication to its adverse effect or adverse reaction. So chloral hydrate is associated with an unpleasant taste. Diphenhydramine, as I mentioned, causes anticholinergic effects. Zolpidem can cause sleepwalking and other bizarre sleep behaviors. Patients will say, I'm talking in my sleep, or I'm wandering around the house, or I'm rummaging through the refrigerator, and I'm binge eating in my sleep has been reported. So pretty unusual side effects, pretty rare. And then finally, phenobarbital is associated with respiratory depression. Okay, that's it for quick review 2. Now's a good time to pause the video and complete the end session quiz, and then restart the video and we'll go through that quiz together. All right, let's go over the answers to the end session quiz. Benzodiazepines are some of the most widely used anxiolytic drugs. Why must you be cautious when prescribing these meds? Well, they can cause a lot of problems. They can cause dependence. They can cause confusion. You can get rebound anxiety, especially with some of the shorter acting drugs. They can also rarely cause respiratory depression. And alcohol and other CNS depressants will enhance their effects. Next question. List the anti-anxiety drug that worked on the following receptors. So first we have the 5-HT1A, the dopamine receptor, and 5-HT2A. The anxiolytic associated with this is buspirone. The next one there, the GABA-A. The anxiolytics associated with GABA-A that act on GABA-A are the benzodiazepines and the barbiturates. Remember, benzodiazepines increase the frequency that those chloride channels open, and the barbiturates increase the duration that those chloride channels stay open. And then the last receptor is the H1 histamine receptor. These are obviously the antihistamines, such as hydroxyzine. Next question. Give an example of a barbiturate with the following durations of action. So the longest acting one there, 1 to 2 days. The longest acting barbiturate we have is phenobarbital. Because of this, it's sometimes used to treat seizures. The next one, 3 to 8 hours, so sort of the intermediate acting barbiturates include pentobarbital, secobarbital, and amibarbital. And then the shortest acting one with a duration of action of 20 to 30 minutes is thiopental. And remember, we said thiopental is used for anesthesia induction because it has such a short duration of action. Next question, name 3 drugs used in the treatment of alcohol dependence. So the 3 drugs that were discussed were disulfiram, naltrexone, and acamprosate. Next question, match the drug to the correct drug class. So first we have lorazepam. Lorazepam is a benzodiazepine. All these end with the suffix epam, E-P-A-M. So you have lorazepam, midazolam, diazepam. I guess they don't all end with epam, but the am in midazolam and so on. The next one, thiopental. This is a barbiturate. Now this is a little tricky. Most of the barbiturates end with barbital, phenobarbital, secobarbital, but thiopental is a little bit different. And then the last one there, zolpidem, is a sleep drug. It's a sedative and hypnotic drug. Next question, which drug is most appropriate in each of the following clinical scenarios? So the first one, a 21-year-old woman who needs reversal of a benzodiazepine after surgery. Well, the drug that reverses benzodiazepine is flumazenil. The next one, a 35-year-old truck driver needs a non-sedating anxiolytic. You don't want to use a benzodiazepine. Those are obviously going to be very sedating. But an anxiolytic that's non-sedating would be buspirone. The next one, a 28-year-old addict in recovery needs a sleeping aid that's not addictive. Obviously, we don't want to give benzodiazepines or barbiturates to patients that are, former addicts. So a sleep aid that's not addictive would be Ramelteon. And the next one, a 52-year-old addict in recovery needs something for his panic disorder. And again, the drugs for panic disorder could include an SSRI. You don't want to use a benzodiazepine for addicts. Next question, which receptors mediate the sedative hypnotic property of benzodiazepines? These are the alpha-1 GABA A receptors. These are the receptors that will put you to sleep. Remember, the alpha-1 GABA B receptors reduce anxiety and mediate muscle relaxation. Next question, name the common potential adverse effects most likely to occur with the following drugs. So the first one, lorazepam. Well, the benzodiazepines are going to cause drowsiness and confusion. Phenobarbital, you can get CNS depression and respiratory depression. These don't commonly occur with benzodiazepines, but they certainly can occur with the barbiturates. And then the next one, chloral hydrate. We talked about the unpleasant taste and also some epigastric distress. Next question, a patient is administered midazolam when undergoing a colonoscopy. His blood pressure is dangerously low. What agent can be used to reverse the effect of midazolam? So midazolam, the brand name you're going to hear lots and lots is Versed. It's very commonly used for conscious sedation during endoscopic procedures, bronchoscopy, intubation. It works very quickly. It can work within just a few minutes. It has a very short half-life, so the patient can go to the recovery room after their procedure, and the drug wears off in a couple of hours, and they can go home. Not at all uncommon, though, if you give too much Versed or too much midazolam or any other benzodiazepine, they'll get a little too sedated. You need to reverse this, wake them up. The drug you want to reach for is called flumazenil. This is a very common test question. I remember very distinctly a test in which I was given a patient who had overdosed, and I couldn't remember the name flumazenil. I knew it was the benzodiazepine reversing agent, but I couldn't remember that specific name. So remember that name. It's burned indelibly in my brain. I hope it's in yours as well. The last one, list the sedative hypnotic agents indicated for long-term use. So the key here is long-term use. You don't want to use benzodiazepines long-term if you can avoid it. So you want to use a non-benzodiazepine sedative hypnotic, such as Ramelteon, zolpidem, zaleplon, or ecopiclone. And that's the end of the end session quiz and the end of the lecture on anxiolytic and hypnotic drugs.